Hi there, my name's Dr. Damien Rowland. I'm a paediatric emergency medicine consultant and I work in Leicester. It's in the middle of England, essentially. I'm a clinician scientist, so I do half-time research and half-time clinical practice. I'm going to be talking today about scoring systems in paediatric emergency care. I don't think I've got any conflicts of interest, I suppose, other than I developed the POPS score, the Paediatric Observation Priority Score, which I'll come on to talk about shortly. I'm going to start off with a little game, essentially. So here we have a number of owls. What I want you to do is spot the cat. There is a cat in there. It's not easy to find, but take a bit of time, look around, see if you can spot the cat. Eventually you will see it. Now, some of you will have seen it very quickly, and some of you will have taken a little longer. But I will break your suffering. Here we go. There is the cat in the bottom left-hand corner. And you can see that because he's got a slightly different nose. Now, the key thing about this particular test is that once you have seen the cat, it's really difficult to unsee the cat. Yeah, it's impossible not to see the cat now in amongst all the owls. And this is a particular challenge that we have in emergency care, particularly paediatric emergency care, is that the retrospectoscope, i.e. looking backwards and judging, is a really easy thing to do. But if you weren't there, if you didn't know what you couldn't see, it's actually very difficult to say in retrospect that something different should have been done. And I think the purpose of paediatric early warning scores and systems is to help clinicians have a framework with which to identify things which might be staring them in the face, but they're just not quite seeing. Now, I want to do a few particular clarifications to begin with. So I'm not talking about triage. Now, triage is a system whereby when an undifferentiated child arrives, you quickly put them into a group who need to be seen immediately, can wait a bit, or can wait a bit longer. And that's all it is. It is clearly a bit about acuity, i.e. the sickest patients need to be seen more quickly, but the purpose or the validation of triage systems is not really about the nuts and bolts of how ill a child is, the heart rate, the respiratory rate. It's just a way of, if you've got far more patients than you have doctors and nurses to see them, who do you see next? That's also different from illness identification. So if you know the patient has asthma, then you can apply an asthma severity score. But if you don't know a patient has asthma, an asthma severity score is completely useless because it's not validated to tell you how sick breathing difficulty is, it's how sick your asthmatic is. So what I'm really interested in this talk is focusing on early warning or systems which allow you to come to a decision in a way that you may not normally have done so. And I will explain why I'm far more interested in a cognitive prompt than I am actually in a decision-making aid. Now, for a long time, well over a decade, we've known that there's been a cycle or a pathway in which these scoring systems can work. First, you have to recognize deterioration. Then you actually have to have staff who can do something about it, that they need to respond in an appropriate way, they need to respond in a timely way, and only then will you improve outcomes. And actually, more recently, it's not really about deterioration, it's about recognizing acuity and dependency. So is that patient best suited for primary care, i.e. your family practitioner, or emergency care? Do they need ward-based care, high dependency care, intensive care? So dependency is quite important. And then also, it's not just about having staff who can recognize things and do something about it. It's about having staff full stop. And most health systems in the world are constrained by a finite number of doctors and nurses. Now, when you look at the literature about applying paediatric early warning scores and systems, specifically in emergency care, it's really sparse. Everyone thinks that you can take an inpatient or a ward-based chart and just apply it in the emergency department. But actually that isn't so. And a kind of a literature review that I've done, actually that probably does need updating now, shows that there actually isn't a lot of high quality evidence at all about the use of these systems in emergency departments. And then there are lots of other factors that come into play when we're trying to use, I suppose, defined systems such as early warning scores to make decisions about patients. So here's the first example. You take an infant who's less than 2 months old. They have no other risk factors, but they've got a temperature. It doesn't matter what their heart rate, their respiratory rate, or anything else is. You know that they've got about a 9 to 10% chance of having some form of infection which needs treatment, whether that's UTI, pneumonia, meningitis, for example. What's interesting, though, is if you ask clinicians what the risk is of having a serious bacterial infection and actually what it is, what it turns out to be in the child, there is no correlation at all. So when people poo-poo scoring systems and go, I don't need them, I'm good enough always to recognize illness, actually that just simply isn't the case. The other problem pews bring with them is that most scoring systems, i.e. when you take a heart rate, respiratory rate, you give it a point allocation, and then you bring all those points together to an overall score. It's fine if the patient is deteriorating and it's activating, or that the patient isn't deteriorating and it's not activating. That's all green. But actually what we know is that most systems overcompensate. So they tell you that something's going on, but actually the child isn't that bad in the first place. And that leads to a lot of frustration. But the reason that frustration happens is because in medicine, we're so black and white about what's negative and what's positive, and there's nothing in between. Heart rate and respiratory rate are a great example of this. Why should there be a difference of a heart rate of 169 and a heart rate of 171? Well, clearly there shouldn't be. But if you, by the necessity of having a scoring system, sometimes one of those heart rates will score 2 and one of them will score 1, even though practically there is no difference at all. And this leads to the challenge in emergency care, whereby if you apply a scoring system that was just meant to pick up deterioration from normal on a hospital ward, but you apply it to an emergency department full of hot and tachycardic children, you will get lots and lots of scores triggering off, higher perhaps than that they need to, with no real cutoff that actually identifies sick children from well children. And so in this study of an emergency department in Australia, there were over 7,000 minutes of additional workload over a year-long period, just because the scoring system wasn't refined enough. And this brings me to this final conundrum of fake pews. If you use a scoring system designed by ward-based for ward-based care, but you plump it into an emergency department, what's likely to happen is it will trigger all the time, but for no added benefits to the patient. So, what are the challenges that we face in the emergency department that a scoring system may be useful for? Well, we have high patient loads. Lots of patients in the department at the same time. I know this isn't always a problem for COVID, but COVID will go away and these high numbers will come back. So how do you differentiate amongst a large group of people who is at most at risk? It's not really about identifying individual patients, it's about stratifying risk for a whole department. There are time pressures. Some of those are standard-based, i.e. in the UK, we have at the moment 4 hours with which to see, treat, process patients. But in most other settings, there is either some target measure or just expectation that the parents don't want to wait hours and hours for treatment. There are multiple handovers, and every time you have a handover, you have a potential for error because you're taking information in one form and giving it to another person who may process it in another way. And this is an example of where a scoring system does come into its own in an emergency department because it's at least objective between handovers. There are inexperienced staff, and by this I don't mean that they're poor quality staff. It's simply the case that in any emergency department or acute care setting, you have staff of different experiences. You always have people learning, and you need a system which can help those who are less experienced in pediatric practice, but doesn't inhibit those who are experienced. And finally, there's loads and loads and loads of diagnostic uncertainty. As I said at the beginning, this isn't about illness detection. We're not making the diagnosis for you. You have to live with the fact that your child with an upper respiratory tract infection could have anything from a simple sore throat pharyngitis to anything which might be a septicemia. So we have to live with the fact that we don't always know the definitive diagnosis when the child leaves the emergency department. And we have even though it's a short timescale, I suppose, in emergency care, there are pathways which we can follow. So a patient presents and they may have any number of heart rate, respiratory rate values, and they either look well or look moderately unwell or maybe look severely unwell. And when they arrive, let's say, for example, they're thought to have sepsis or they're not thought to have sepsis. But actually, they can be any one of four things. They can be thought to have sepsis and have sepsis. They can be not to have thought to have sepsis and not be septic. And what we need to do is get patients into optimal treatment and outcomes. So if you're not thought to have sepsis and you're not septic, that's fine. But if you are, how do we get you recognized as having sepsis and how do we get that treatment into you? When you arrive and you are considered to be really unwell and you are unwell, how do we get those antibiotics into you as quickly as possible? And you can apply this framework that there's junction A's, B, and then sometimes C, D, and onwards to lots of illnesses. It's not just about sepsis. You could apply this, I suppose, to fractures and all sorts of treatments. So what we're looking for, it's not just a one-stop shop. We're not using the scoring system at one point in time as the sole arbiter of a particular outcome. It's going to happen at lots of junctions. So we need scoring systems to reduce knowledge deficit. We need to help those who don't have pediatric experience. But those who don't have pediatric experience, the scoring system needs to escalate and get senior review. We need to be thinking about not the most ill patients, but also those patients who can go home. And in fact, one of the biggest things that we can do is identify wellness and get the well child home as quickly as possible, because that will declutter the emergency department. And in all cases, we need to improve communication, because ultimately what we're trying to do is decrease cognitive load on any member of staff, whether you're a doctor or nurse in the emergency department, because that will help you make good decisions. This is the Pediatric Observation Priority Score. There's nothing complex about it. I pulled some numbers originally from the APLS, and what myself and Dr. Fionn Davies, the co-creator, did was create some traffic light bands, green, amber, and red, to highlight a level of acuity that you can go from 0 to 16. We know from testing that we've published that actually, if you apply the same patient, we did this via video, to different participants, so 1 to 12 here, actually the scores generally are very similar, even with very minimal training. And you can see in our emergency department, this is of 20,000 children, actually the scores are mostly in our department actually 0, 2 to 3. There aren't loads and loads and loads of sick patients, but most nursing staff, and that they're all de-anonymized here, do the same threshold. And that's really useful because we know the score's working in the same way. Now, I'm really keen that an individual score doesn't determine your disposition, but we do know as soon as you go above a POPs of 4 to 5 and you are admitted, lots of children with POPs of 4 or 5 are discharged home. But if you are admitted, you're likely to be in hospital for more than 24 hours. And that helps with kind of management type decisions. And if you use POPs in different hospitals, so 4 different hospitals in the UK here, you'll find that they're not exactly the same. You wouldn't expect them to be, but actually the bandings again are very similar, so that there's equity between units, which means we can start making some decisions about who are usefully admitting patients and perhaps those who are a bit overcautious or a bit undercautious. And so as you can see here, there are some hospitals which have slightly different thresholds about who they're going to admit or not. And that's a normally good thing, but it's something that we can validate and follow over time. So POPs itself is a cognitive prompt. It's not a decision-making aid. And just for an example, its popularity has meant that people have started translating it into lots of different languages, which is it's really nice to see. But ultimately, observation is the key thing that is going to help children in this situation. And what we do in our emergency department is do a POPS score every hour. It's not, we don't always manage to do that, but that's what we try and do, so that over a 2 to 3 hour period, we have a number of POPS scores, which become an investigation. They're as good as a blood test, really, in watching the trajectory of illness in any given child. And so it's not about the score telling you what to do. It's not about the score even telling you to highlight to PICU or escalate care. It's about having a particular score that recognizes a particular risk in a particular patient. So thank you for your time, and I'm very happy to take questions.